In this PowerPoint, we're going to review resuscitation and how a neonate transitions to the extrauterine life after birth. Let's go to our next slide. There are three primary stimulus for the first breath, and we've talked about these in our previous unit. It includes asphyxia, compression of the thorax, and environmental changes. With asphyxia, while passing through the birth canal, blood flow to the fetus is disrupted, which causes a decrease in PaO2. These stimulate the chemoreceptors, which in turn stimulate the respiratory center in the brain to signal the respiratory muscles to perform the actions necessary for the first breath. Remember, the chemoreceptors have been active since about week 23 in utero, so they've been mimicking breathing this entire time during gestation. Now that they're born, the stimulus is increased due to the asphyxiating event. Let's go on to compression of the thorax. This occurs while passing through the birth canal. This does two things. One, it helps squeeze fluid out of the lungs, and as it exits, the chest will recoil, expand to its original size and shape. The recoil creates a pressure change to allow air to enter the lungs. Lastly, we have the environmental changes. These are abrupt change from dark to light, from warm to cold, and from the physical handling of others, because this whole time it's been surrounded by amniotic fluid, and any type of movement has been shielding the baby from the abrupt impact of it. All of these will invoke the crying reflex, which stimulates the first breath. Remember, the first breath has to overcome the surface forces of the lung, the alveoli. These have been measured to be as high as negative 100 centimeters water pressure. This doesn't mean that you could give 100 centimeters water pressure of positive pressure to get their first breath going, but to know that when they're sucking in, that's how much surface tension they're overcoming. This initial breath, which is hard to do because of the surface tension, establishes the functional residual capacity. Each successive breath is easier because the surfactant prevents the alveoli from collapsing now, allowing them to remain open and partially filled with air, i.e. natural PEEP. Let's go on to our next slide. So how does the fetus change to adult circulation? Well, on this slide, I'm showing you a very streamlined version of what is occurring. And for some of you, this may be the easiest way to remember it. In our next slide, we're going to see how all of these are really intermingled. So first of all, the pressure changes that occur require cord clamping, initiating of breathing. The initiation of breathing causes inflation of the lungs and development of the functional residual capacity. This decreases compression of blood vessels surrounding the lungs. Inflation of breathing also increases the PaO2. This relaxes the pulmonary smooth muscle, again opening up the pulmonary blood vessels to increase blood flow. The closure of the shunts requires, for the foraminal valve, you need an increase in pressure on the left side or on the systemic side, and you need a decrease of pressure on the right side. If both of these things don't happen, the shunt will not close. The foraminal valve may stay open. For the ductus arteriosus, we need an increase in the PaO2. This specifically causes a decrease in prostaglandin production, which causes the ductus arteriosus to close. Let's go on to our next slide. I really like this slide because you can see closely how fetal circulation differs from adult circulation, the blood flow, where the shunts are, and how things have switched from one to the other. Let's go to our next slide. So now let's consider or imagine what would happen if one of those requirements from 2 slides back didn't occur. For example, what if the first breath does not occur right away? What would be the outcome of that? Or consider, what if the first breath is weak and gasping? Or consider, what if the PaO2 does not increase? Maybe they're breathing, but their PaO2 doesn't increase. And finally, what if their lungs are too stiff for the baby to inflate on its own? So it's trying to breathe, but it can't inflate those lungs. What's going to happen? Well, let's go take a look at our next slide. This slide is kind of a flow chart of what needs to happen in order for circulation to change from the fetal circulatory pattern to the adult circulatory pattern. On the left-hand side of your screen, you see that it states the purple is the fetal circulatory pattern. It has a decrease in pulmonary blood flow, an increase in lung fluid, and a decrease in systemic artery pressure. Back to the fetal circulatory pattern box. When there is a stimulus for breathing, the neonate, and it's born, the neonate will breathe regular air. This causes lung expansion. The lung expansion causes two things. One, it increases the PaO2, and two, it decreases the PCO2. A direct result of the increase of PaO2 is a ductus arteriosus closure. A direct result of the closing of the ductus arteriosus is a decrease in pulmonary artery pressure, a decrease in right heart pressure, and that directly causes the foraminal valley to close. Now, going back up to the decrease in PCO2 caused by lung expansion, this specifically causes a decrease in pulmonary vascular resistance, as did the increase in PaO2. The decrease in pulmonary vascular resistance also decreases pulmonary pressure. It also decreases right heart pressure and contributes to the closure of the foraminal valley. So the most specific cause of the foraminal valley to close is a decrease in right heart pressure. Things that help the decrease in right heart pressure include a decrease in pulmonary artery pressure, a decrease in pulmonary vascular resistance, and closure of the ductus arteriosus. So you see how all of these things are truly intermingled. It's not just one specific thing. Now, if we go on down to the bottom, we see where the cord is clamped, and we see how that contributes to everything. The clamping of the cord decreases umbilical and placental blood flow. This increases systemic vascular resistance, which also contributes to the closure of the foraminal valley. Another thing of the decrease in umbilical and placental blood flow is it helps the ductus venosus close, which that one we don't really care about. Now notice if we look over to the adult circulatory pattern, they have an increase in pulmonary blood flow, a decrease in lung fluid, and an increase in systemic artery pressure. Notice what causes an increase in pulmonary blood flow. That is directly related to a decrease in the pulmonary vascular resistance, which occurs because of the increase in PaO2 and the decrease in PaCO2, which is caused by lung expansion. Lastly, if you go down to the increase in systemic artery pressure, that is a direct result of an increase in systemic vascular resistance, which is directly caused by the decrease in umbilical and placental blood flow once the cord was clamped. So we see there are major things occurring, and they're all intermingled a little bit, but if you follow this flow chart, you can trace back what the most specific cause of each one is. So let's go on to our next slide. A couple slides back, you were asked to imagine what would happen if one of the requirements didn't occur. You were asked, what if the first breath doesn't occur? What if it's weakened gasping? What if the PaO2 doesn't rise? And what if the lungs are too stiff for the baby to inflate it on its own? Well, these are the reasons why we resuscitate. If any of those things were to happen, then the alveoli would need to be manually opened. To do this, we would bag the baby or provide positive pressure ventilations. The initial breath would be 40 centimeters of water pressure, and the subsequent breaths would be 20 to 25. You'd look for that good chest rise to know that you're manually opening those alveoli. Hypoxia, hypercarbony, and acidosis would continue if we didn't provide positive pressure ventilation, and this would cause pulmonary hypertension to continue. The pulmonary hypertension, if not resolved, would cause an increase in pressures on the right side of the heart, and systemic pressures would be high anyway because of the cord being clamped. The high pressures on the right atrium would cause the foraminal valley to remain open. Even though the left-sided heart pressure is already increased, the foraminal valve can't close if the right heart pressures don't drop. Hypoxia, the continued hypoxia, would cause prostaglandins to continue to be produced, and the increased levels of prostaglandins would prevent the ductus arteriosus from closing. So if we wouldn't provide positive pressure and if we wouldn't manually open those alveoli, those are all the negative things that would occur. So to perform neonatal resuscitation, again, you're going to start your positive pressure breath. Your initial breath would be 30 to 40 centimeters of water pressure, and then each breath after that would be about 20 to 25 centimeters of water pressure. You're going to deliver those breaths at a rate of 40 to 60 breaths per minute. These provide necessary lung inflation They help the heart pressures change as they need to, and it increases the PaO as needed. Those will allow the shunts to close. And again, if we don't do that, the risk that we pose to the neonate is continued pulmonary hypertension. The pulmonary pressures remain high, and the foraminal valley can't close, and prostaglandin production would continue, and the ductus arteriosus would remain open. When this happens, we have a name for it, and it's called persistent fetal circulation. Let's go on to our next slide. So to prevent this from occurring, the number one intervention we can do is effective ventilations. Effective ventilations immediately following birth are needed in order for baby to have a successful transition to life outside the womb, help close shunts and switch over to adult circulation, and in order for the heart rate to be established greater than 100 beats per minute, you need to have effective ventilations. If your heart rate drops, the first thing you do is provide positive pressure ventilations, and if they are effective, you should see that heart rate rise very quickly. Let's go on to our next slide. Successful transition to extrauterine life includes the following next steps. A physical assessment. Here you're going to assess for gestational age, assess for their size. Then you're going to continue monitoring and assessment. Here you'll perform respiratory assessments, vital signs, thermoregulation, and fluid balance. Then you have your general care considerations, and this is your behavioral-based care, kangaroo care, and the effects of stimulus. Let's go on to our next slide. The APGAR scoring system is done typically at 1 minute, 3 minutes, or 5 minutes, and sometimes at 7 minutes following birth. So 1 minute and 5 minutes for sure, and some facilities also do it again at 7 minutes. A on APGAR, the first A stands for activity, and here what you're really looking for is your muscle tone. You get 0 points if they have no muscle tone, if they're flaccid. They get 1 point if their arms and legs are flexed, and they get 2 points if they have active movement, meaning their arms and legs aren't just flexed, but they're moving about. The P stands for pulse. If it's absent, they get 0 points. If it's below 100, it's 1 point, and over 100 is 2 points. G is for grimace, which is really reflex irritability. And this is, if they're flaccid, they get 0 points. If they have some flexion of the extremities, then they get 1 point. And if they have active motion, which includes sneezing, coughing, and pulling away, they get 2 points. The second A in APGAR is for appearance, and here you're actually looking at skin color. If they're blue or completely cyanotic, they get 0 points. If their body's pink but their extremities are blue, and we call this acrocyanosis, they get 1 point. And if they're completely pink, they get 2 points. Lastly, we look at their respiratory effort. If it's absent, they get 0 points. If it's slow and irregular, they get 1 point. And if they have a vigorous cry, they get 2 points. Now, what this system actually tells us is how they're responding to resuscitation. It tells us if our CPR or our NPR has been effective, and it can indicate future impairment, meaning a low score puts the neonate at a higher risk for long-term damage. So if you score lower, that means your CPR has been less effective than if you scored higher. Okay? The score itself does not determine what type of CPR you're going to provide or what interventions you're going to include. For example, let's say you have a neonate that scores a 3. Well, they only got 3 points, so it could be that their heart rate's below 100, and if that's the case, you would need to provide positive pressure ventilation. But maybe they got 2 points for their heart rate, and then maybe they got 1 point for some flexion of the extremities. You don't know where the points come from. So based on the score alone, you cannot determine what interventions you're going to use. You just can determine how effective your resuscitation has been, if that makes sense. Please post questions on this if you have them. Let's go on to our next slide. Here's another look at our APGAR scores. Again, if they score between 7 and 10, there's no asphyxia. They consider this a successful resuscitation, and you just need to monitor. If you scored 4 to 6, then they have mild to moderate asphyxia. PPV is probably still required depending on the score for the heart rate or the pulse, but you're going to have some continued resuscitation efforts. If they scored 0 to 3, this is severe asphyxia. You're still going to be continuing resuscitative efforts. You're probably providing PPV, and you're most likely providing some chest compressions, but not necessarily. So again, the score itself doesn't tell you what to do. You have to look at each individual assessment, but it does tell you how effective your resuscitation has been and if you just need to monitor or continue to resuscitate some more. Let's go to our next slide. Okay, what do you think the APGAR would be for this baby? And we're going to give it a pulse of 122. And respiratory effort, we can't really tell through this pics, but it does look like he's screaming his lungs out. So I'm gonna let you work on that and for just a second, and then I'm gonna tell you what I came up with. Okay, so here is how I would evaluate this one. First, for activity, I would say it looks like some good muscle tone there. Looks like they're flexed, but maybe not moving. So I would give that 1 point. Next, the pulse, we have 122. That is over 100, so that's 2 points. Next, we have grimace. I see a good grimace there. It looks like there's some reflex irritability, so let's give that another 2 points. And then we look at our respiratory effort. Again, it looks like he is screaming, maybe crying. So that's going to go, I'm going to give that one another 2 points. So, and then skin color, he's acrocyanotic. That would be 1 point. I came up with an 8 on that one. Once you're done considering this slide, let's go on to the next slide. Alrighty. In this one, I'm not asking you to tell me about your APGAR, but I do want you to take a close look and tell me what looks wrong with this baby here. The problem with this baby, he's got nice pink color. Look at that, nice pink cheeks, nice pink belly. But the problem is he has what's called a scaphoid abdomen. Notice how flat his belly is. His chest looks bloated, but his belly is flat. When you see this, this is not a good sign. It suggests that they may have a possible diaphragmatic hernia. This kiddo doesn't look like he's in any respiratory distress, though, which is actually kind of odd. But that could be what's going on with the scaphoid abdomen is a diaphragmatic hernia. Typically, if that's occurring, then the stomach contents are up in the chest cavity, compressing the lungs, and they typically do have respiratory distress. That would need to be intubated, and they would need to go to surgery to fix the diaphragm at some point. Like I mentioned before, the chest on here looks bloated with an increased AP diameter of the chest, or if the chest is greater on the left side than the right, then you would be suspicious of a pneumothorax. A quick detection for this would be called transillumination, and this is where you hold a bright light up to the baby's chest, and you can actually see through their skin, and you would be able to detect where the pneumothorax was if it was present. And then if it's barrel chest, the AP diameter is greater than normal, it would be an indication of air trapping. Before auscultating the chest, you would want to notice the shape and symmetry of the chest wall. In this infant, the AP diameter appears greater than normal, and there was a concern that the AP diameter of the left chest was actually greater than that on the right. Notice the white lead on the right nipple and the gold lead over the midline. Just to point out, the gold lead is the temperature sensor, and so it tells the radiant warmer when to heat up and cool off, and the right lead is an EKG monitor. So back to the findings of his AP diameter. This was a suspicious finding, and they considered it was maybe a pneumothorax, which those can occur spontaneously in newborns when they're trying to get those first breaths. Then they, like I mentioned before, a congenital diaphragmatic hernia was also of concern, and that's typical when you see the abdomen so flat like this. And actually that was the case with this infant. It did have a congenital diaphragmatic hernia, and he did not develop severe respiratory distress, but he did end up going to surgery and having it fixed, and he was doing well. Okay, let's go on to our next slide. Okay, back to APGAR. I'm going to say his pulse is 104, and I'm going to let you guess on the rest here. I'll give you a few seconds, and then we'll go through them together. Okay, for the first A activity, looks like he has a little bit of muscle tone, but it doesn't look like he's moving, so we're going to give that a 1. For the pulse, I said let's give him 104, so that gives him a 2. Grimace reflection, it looks like he has a little bit of a grimace, but it doesn't look like he's flexing his limbs, so we're going to give him a 1. And then for respiratory effort, or appearance, skin color, this kiddo is cyanotic. He is blue, so that gets him a 0. And then for respiratory effort, it's difficult to tell, but it does look like he might be crying, so let's give him a 1. Based on that, I came up with a 5. Alrighty, let's go on to our next slide. This is the last one, and this is a picture of a successfully resuscitated baby. It has been intubated. It's on the vent. You see your ventilator circuit. You see your ET tube. You see your suction catheter attached. Notice with babies' ET tubes and circuits, they have a Y connect where the suction catheter goes down. This kiddo has an umbilical artery in place, it looks like. And you see your EKG leads. And you can't really see your temperature lead on there, but this kiddo's doing pretty good. This concludes this PowerPoint.